I have no disclosures of any conflicts to make to you today. I'm going to talk about a number of medications used in the treatment of symptoms associated with autism, and each of these is used in an off-label manner other than risperidone and aripiprazole, which are approved by the FDA specifically for treating irritability in children and adolescents with autism. Recently, there's been a major change that's occurred in the diagnostic criteria for autism-related disorders. Most of you were familiar with the DSM-4 TR criteria, and in the spring of 2013, the fifth version of the Diagnostic and Statistical Manual was released. So it's important for you to be familiar with both sets of criteria during this period of transition. Let's start with a bit of a review of the DSM-4 criteria. In that set of criteria, autism fell under a category referred to as pervasive developmental disorders, or PDDs. And the term pervasive really meant that these are lifelong disorders, rather than implying that there are multiple areas of development that are affected, although at times that's true. And I'm going to describe each of these 5 subtypes of PDD in a little bit of detail for you now. Let's start with autistic disorder. This is a picture of the first child psychiatrist in America, whose name was Leo Kanner. And Dr. Kanner was at Hopkins at the time, and he published a paper in 1943 in a journal called Nervous Child, in which he described 11 children with autism in some great detail. So that was the first description of autism in the world literature, and it's a paper I'd encourage you to track down and read. So in DSM-4, there were 3 core symptom domains in autistic disorder. These included an impairment in social interaction, an impairment in communication, and we know that about 30 to 40% of people with autistic disorder never develop meaningful verbal communication at any point during their entire life. And the third symptom domain related to restricted repetitive behavior and thoughts. And it's important to emphasize that this is very different from obsessive compulsive disorder, in that most times these individuals engage in these behaviors because they're rewarding. They may have a fixed interest that they find enjoyment in thinking about, or they may do something like rock or flap their hands that is probably designed to help them feel more calm. So quite different from OCD, and I'd encourage you not to refer to it as OCD. This is a picture of a pediatrician, Hans Asperger, who practiced in Austria. And his paper was written in 1944 describing boys with Asperger's disorder 1 year after Leo Kanner wrote his paper. Interestingly, the Asperger paper wasn't translated into English until 1980. So even though it's of historical importance, it didn't hit the United States until a number of decades later. And how is Asperger's disorder different from autistic disorder? Primarily in 2 areas. Number 1, people with Asperger's disorder have no delay in language development. So they speak normally with regard to the age of onset of appropriate language milestones, and they speak in complete sentences, etc. There may be some abnormalities in their pragmatic use of language or the tone or volume of their language, but it's quite different from someone with autism who may not be able to speak at all. The second primary area of difference is that people with Asperger's disorder have no delay in cognitive development. This essentially means that they don't have any degree of intellectual disability, whereas probably 50% or so of people with autism have comorbid intellectual disability. The other thing to emphasize is what we refer to as all-encompassing preoccupations. So most of us are really interested in something when we're not working, if we're not working. And for example, I'm very interested in the Beatles, if you've ever heard of the Beatles. And I'm also very interested in Indiana University basketball. You might have heard of Bobby Knight. So, but this is something I enjoy thinking about, right? It's not an obsession that causes distress where I try to push those thoughts out of my mind. And this is what you might see in Asperger's disorder. So don't refer to these as obsessions. These are actually preoccupations. Dr. Rett was the first to describe Rett's disorder, which is quite different from the other PDDs. For example, Rett's disorder only occurs in females, and we know that in autistic disorder and Asperger's disorder, the male to female ratio is 4:1. So this is quite different. These are little girls who are born quite normally, but what happens over the first couple of years of their life is that their head stops growing at the rate that it should, meaning that their brain stops growing at the rate that it should. They also develop some hand movements that are somewhat unusual and stereotyped, and this is very different from hand washing. For example, a concern about dirt and germs. This is non-purposeful hand movements, and eventually they may lose use of their hands. They have a significant social problem, severe language disorder, and severe to profound intellectual disability. So because Rett's disorder is so different from the other subtypes of PDD, you'll see that in DSM-5 it has been removed from the Autism Spectrum Disorder category. Childhood disintegrative disorder, which has also been referred to as Heller's syndrome, was also included in DSM-4, but not in DSM-5. And these are children that have entirely normal development until they're between the ages of 2 and 10 years. And then they become autistic, if you will. They begin to lose skills that were normal, that had developed normally. And so that you can imagine what a terrible event this might be in the lives of the parents when they've had a normal child for between 2 and 10 years, and then they regress. And they lose skills in all of the behaviors associated with autism, including social behavior, language, and then they develop repetitive behavior. Now you may say, well, I thought that people with autism could have regression as well, and they can. In about 25 to 33% of cases of autism, the child will have relatively normal development and then lose skills. But in those cases, the regression typically occurs between 15 and 18 months of age. So this is a much later age of deterioration. Pervasive developmental disorder not otherwise specified, PDD-NOS, was the most common of the PDDs. And this is more of a catch-all term for individuals with a prominent social disability who don't meet criteria for autistic disorder or Asperger's disorder. They may have a later age of onset of symptoms. They may have symptoms that don't meet full criteria for these other disorders, for example. You'll see on this slide that the actual symptom domains comparing DSM-4 and DSM-5 are depicted. And what you see here is that the 3 core domains that were present in DSM-4 have been collapsed into 2 domains. So the first domain under Autism Spectrum Disorder refers to an impairment in social communication and interaction. What this essentially means is that the previous domain that focused on communication or language has been minimized. The second domain in DSM-5, the restricted repetitive behavior, has been retained from DSM-4, But an important addition has been made, and that is criterion 2D on this slide, referring to hyper or hyporeactivity to stimuli. Parents have been telling us for a number of years that their child has either heightened sensitivity to the five senses or reduced sensitivity. And this can be one way or the other, or some mixture to sight, sound, touch, smell, and taste. But finally, this has been included into the formal criteria. This is important for a number of reasons. It tells us that we've been listening to parents, that they find this symptom to be interfering to their child, and this will allow us to collect data on the prevalence of this criterion and the type of sensory disturbances that these individuals have. Hopefully this will lead to research into the underlying biology of these disturbances and eventually to treatments that can be helpful. This slide summarizes the major changes that occurred in the diagnostic switch from DSM-4 to DSM-5. So number one, autistic disorder, Asperger's disorder, and PDD-NOS have now been collapsed into one diagnosis called Autism Spectrum Disorder, or ASD. Number two, the impairment in verbal communication has been eliminated and essentially combined with social impairment into one symptom domain. Number three, the criterion referring to sensory abnormalities has been added and highlighted. And number four, ASD, there's now a modifier that can be applied to that diagnosis with respect to mild, moderate, or severe impairment. And largely, this focuses on the intellectual disability and the speech component. Let's switch from a discussion of diagnosis to a discussion of an evaluation of a patient with ASD presenting to your office. So you're busy pediatricians and primary care providers. You're not based at an autism center where you have lots of people there that are trained in this area and who utilize the gold standard diagnostic approaches. You have to do this much more quickly. So my thoughts around diagnosis are that you use the DSM-5 criteria. I don't feel it's important for you to learn how to administer the Autism Diagnostic Interview Revised, the ADIR, which is an interview you do with a parent that can take you from 45 minutes to 90 minutes. I don't recommend that you do the Autism Diagnostic Observation Scale, the ADOS, which is an in vivo behavioral interview that could take you an hour or more. You simply don't have time to do that. So do your best with the DSM-5 symptom criteria. You always want to do a physical examination, and this can be helpful for a number of reasons. These patients are going to present to you with irritability, with symptoms of self-injury, property destruction, aggression toward others, hyperactivity, sleep disturbance, and you want to make certain that there isn't an underlying medical problem that's contributing to these behavioral symptoms. And many of these patients aren't going to be able to communicate the source of pain to you. If they can't talk, if they have impaired cognitive ability, you're going to have to really use your physical examination skills to rule out underlying medical problems. Very, very important. Neuropsychological testing is essentially used to determine the individual's IQ or cognitive ability. And I say that as though it's easy. It's very difficult to get an accurate IQ, again, on someone that is nonverbal, because our IQs are generally, IQ tests are geared toward assessing IQ in typical people. So many of us don't have a lot of confidence in the IQ numbers that are generated from standard neuropsychological testing. And you could also debate for a long, long time how to define intelligence anyway. So many of the people with autism have skills that are certainly better than mine in numerous areas, and we may not be giving them credit for those abilities in standard psych testing. So it gives you a ballpark ability on to determine their cognitive functioning, which is going to be important for school placement, so that the individual is in the best classroom setting, and so that the instructors are presenting material in the way that the person's brain best receives and understands it. You should do genetic testing on every patient in whom you consider a diagnosis of autism spectrum disorder. And what should you order? Currently, you should order something called a chromosomal microarray, and you should order a test to rule out Fragile X syndrome. The chromosomal microarray is going to identify almost every possible genetic abnormality. And currently, there may not be a lot of relevance to the finding to helping the individual. At times there will be. But over time, we're going to find that findings on the chromosomal microarray are going to begin to inform us in generating meaningful subtypes of ASD. The reason you want to test for Fragile X syndrome in every patient with ASD is because if you have the gene for Fragile X, we're actually talking about the X chromosome. And if you're a male, you have one X chromosome and a Y. And if your X chromosome is affected, you don't have another X chromosome that's normal to kind of balance the impairment. So you're going to have Fragile X syndrome, and you're going to have intellectual disability and significant impairment your entire life. If you're a woman and you have two X chromosomes and one of them is affected but the other is normal, the normal chromosome is going to help balance the issue. So you may have some depression or anxiety or social issues, but you're generally going to be normal functioning. And if you carry that bad X as a relatively normal functioning female, and you get married and you have a child, there's a 50-50 chance that the impaired X is going to go to your child. So the odds for moving this gene forward are good, if you will, 50-50 chance, but for the baby, those aren't good odds. So if you identify a Fragile X in a patient, people of childbearing potential who are blood relatives of that individual need to be tested as well. You know, one question would be, should you get an EEG or a brain scan, a CAT scan or an MRI on individuals with an ASD? We don't typically get either one of these unless there's a clear clinical presentation for a possible seizure disorder. And that could be tonic-clonic activity, or it could be something like just staring for periods of time, which might represent an absence or petit mal seizure. With regard to getting an MRI or a CAT scan, again, we wouldn't pursue this unless there was something on your physical exam or something you obtained in the history that would make you wonder about an anatomical abnormality. The other major problem here is going to be the individual's ability to cooperate with this testing. So imagine a very hyperactive young child with autism, and you're going to want to put all of these EEG leads on their head with glue. They may not remain on the child's head very long, and the process is going to be extremely disturbing and upsetting to everyone. For brain scans, you may need to use general anesthesia in order for the child to be still enough to get an adequate image. And that has significant risk associated with it. So by all means, you want to obtain these tests if they're indicated, but not in a routine manner. Once you make a diagnosis, You then want to think about treatment approaches. And you want to think about what I would refer to as non-medication and medication approaches. And a lot of this is going to depend on the type of symptoms the individual presents with. It's going to depend on their age, and it's going to depend on whether they're still in school or if they're out of school and looking for vocational or post-high school educational opportunities. So behavior therapy, I'm going to talk about in very general terms, but this is using a behavioral strategy to try to shape or change the person's behavior, largely based on consequences and rewards. And behavior therapy, when it's delivered early on in a higher functioning person with autism's life, like soon after diagnosis at age 2, 3, 4, or 5, can have a significant impact on long-term outcome with regard to social behavior and language usage. Almost everyone with an ASD is going to have some element of speech and language problem, whether it's being non or minimally verbal or having plenty of language but using it in a socially inappropriate manner. People will need speech and language therapy. Occupational therapy in the setting of ASD is really geared toward things like the sensory impairment. So these are the clinicians that know how to address the hypo and hypersensory stimuli in the 5 senses that can be quite interfering. These people are also very good at working on fine motor skill impairment, things like trying to tie your shoes or handwriting or using eating utensils. Physical therapy is not that commonly needed because most people with ASD don't have prominent physical abnormalities, but at times they may. When we think about autism, certainly social impairment is at the heart of the syndrome. So social skills therapy, whether that's individual therapy or group therapy, can be very useful. And there's always the question, do we put a person with an ASD in a group with more typical people so that they can see others modeling appropriate social behavior, or do we put them with other individuals with ASD so they feel more comfortable in the setting? But many times the social skills for people with ASD are things that are learned, at least initially. So we teach them how to make eye contact, even though they may not see the purpose for it or want to do it. We teach them about greeting others appropriately. And they can learn these skills and master them, and over time they may become more natural. With regard to educational placement, again, this is a huge issue. And as I mentioned before, this is where results from neuropsychological testing can be helpful to determine the individual's ability to focus and concentrate, to determine the way they learn best, that kind of thing. And when these people are in school, some of them will be mainstreamed in a regular classroom, but they may need an aid in the classroom to help them remain focused. They may need to be pulled out of the mainstream classroom for certain classes like reading or math where they struggle. At other times, they're going to need so much attention academically that they're going to need to be in a separate classroom with a smaller number of students and a greater number of educators. So it depends on both the educational ability of the child and any behavioral issues. I'm a believer that we should challenge individuals and give them the benefit of a doubt and push them until their behavior or their performance tells us that they're no longer able to participate at that higher level. And parents may say, how do we know when that's happening? And their behavior will tell you when that's happening. So at some point during the school period, most people, there'll be a decision about should we continue along an academic track where we're thinking that this individual may have the potential to do some amount of college, or should we switch to a more life skills track because this person isn't going to go to college and time may be better spent teaching them how to work with money or how to travel on public transportation and things along those lines. It's very important, this gets back to the physical exam, if you identify comorbid medical problems, that you treat them. So over time, about a third of individuals with autism will develop seizures. And there are two primary points of onset for the seizures, early in life and then later in late adolescence or early adulthood. So you may have a patient who's on spring break with their parents in Florida that out of the blue has a grand mal seizure when they're 18. This is not unexpected, so you should be mindful of that possibility. The other thing you're going to see medically is you're going to see a fair amount of GI, gastrointestinal problems, whether this manifests as diarrhea, severe constipation, gastroesophageal reflux disease. These are things that need to be worked up and treated. And you may not be aware that this GI problem is underlying their aggression, for example. And you may then get an x-ray of the abdomen and find that they're severely constipated. So you always want to think about underlying medical problems before you assume it's behavioral in nature. As these individuals move into high school, usually they can stay in the high school setting until they're 22 years of age. And it's not uncommon to begin transitioning into a vocational opportunity between the ages of 18 and 22. Now, that then gets into a major issue, and that is the relative lack of resources to put these people into jobs when they finish high school. So many times they're going to need a one-on-one job coach. That's very expensive. Society currently doesn't have the resources to provide that. So unfortunately, many of these post-22-year-old individuals attend a day program where they may do crafts or go on outings. But if this was your child, I would hope you would feel that that wasn't an acceptable setting for the rest of their life. So public policy and advocacy for those who are beyond the age of 22 is really, really needed right now, because our lives aren't over at the age of 22. And these individuals live as long as the rest of us do. So society, including you and I, have some responsibility to begin helping these transition-aged individuals have a better quality of life. Finally, let's talk a little bit about the use of medication, which is only part of the treatment approach, but as a pediatrician or primary care provider, this may be an area where you're going to be needed because there simply aren't enough child psychiatrists in the world to do this. We all have very long waiting lists, and it's going to be important for you to better understand the basics of using medicines in this population. So when we think about the use of medication in these folks, I like to think about groups of target symptoms. There are no medications that are used to treat what you may think of as autism spectrum disorder. There's no medicine that's been shown to be consistently helpful for the social impairment, for example, or for the language impairment. And to date, there's no medication that's been shown to be consistently helpful for the interfering repetitive behavior of autism. So the 2 or 3 primary core symptom domains are largely addressed through these non-medication approaches that I've reviewed with you. I'm going to talk a bit about 5 different domains, including motor hyperactivity and inattention, interfering ritualistic behavior, aggression, self-injury, and severe tantrums, depression, and then a group of things including anxiety, sleep disturbances, and inappropriate sexual behavior. Let's start with motor hyperactivity and inattention. You may say, well, that's going to be very easy, Dr. McDougall, that's ADHD. We know how to treat ADHD. And I would say, well, currently, DSM-5 does allow you to diagnose comorbid ADHD in ASD. But in DSM-4, the criteria didn't allow a comorbid diagnosis of ADHD if you gave the patient a diagnosis of a PDD. So this remains somewhat in flux with regard to how to approach this comorbidity. The first thing I would say to you is we know that in classic ADHD, the most effective drug treatment is a psychostimulant. And these work 70 to 80% of the time in people with typical ADHD. It's important to know that in individuals with ADHD that have ASD, the rate of response is much, much lower, closer to 25 to 30%. And the rate of adverse events and dropout of treatment due to adverse events is much, much higher. So I really want to caution you on jumping right into treating comorbid ADHD with a psychostimulant. And we're going to talk a little bit more about this. So considering that caution, you may want to think about the use of non-stimulants to treat ADHD, including alpha-2 agonists and atomoxetine. Let's talk a bit about the psychostimulants. So there are essentially two categories of psychostimulants, right? There's the Ritalin or methylphenidate group, and there are a number of medicines within that grouping. And then there's the amphetamine grouping, Adderall and Vyvanse and a number of other medications. The good news about psychostimulants is that they work quickly. So you're going to know if they work or not within a few days. You actually would put the medicine in your body, you can feel it right away. You don't have to wait 3 or 4 weeks to see an effect. So I often, if I'm going to use a psychostimulant, and it's rare that I will start with a psychostimulant, I will do it on a weekend. And I will start with the lowest dose possible. Let's take methylphenidate, for example. I would give 2.5 milligrams on a Saturday morning and 2.5 milligrams around 1 o'clock on that Saturday to see what might happen. And we're looking for improvement or behavioral worsening, where there's an increase in the symptoms you're actually trying to improve. If nothing happens Saturday, Sunday, I would give 5 milligrams in the morning and 5 milligrams at 1 p.m. And I would continue along that manner, increasing by 2.5 milligrams twice administered daily, every day, until we see significant improvement or behavioral worsening, or we reach a dose beyond which we shouldn't proceed. And within a week, you're going to know which way to go. Some practitioners would say, well, because I'm going to know within a week, I like to start with a psychostimulant. And that's a reasonable idea. I'm on the other side of the risk of worsening behavior is so great, I'd rather start with a medicine that is going to either help or do no damage at the beginning. What are the side effects of psychostimulants? Well, if you think about these in some ways as diet pills, they can reduce your appetite. And if the individual is already a picky eater and is quite thin, this may not be a good choice. The other thing is these are stimulants. So if they're given too late in the day, often beyond 1 or 2 in the afternoon, they could cause disturbances with falling and staying asleep, which is a major problem in ASD anyway. The other thing to be aware of is that people with ASD are more likely to have tics than the average person. And the term tic gets used inappropriately many times. So these are involuntary motor movements like bilateral eye blinking, shoulder shrugging, facial grimacing. Those are motor tics. Or you could have vocal or phonic tics. Nasal sniffling, throat clearing are very common. If the person has tics at baseline, it's highly likely that a stimulant is going to make them worse. And this is entirely reversible when you stop the stimulant, but you need to be aware of this. The third bullet says that we can cause behavioral worsening with a stimulant, and I think I've already emphasized that to you. The fourth bullet says this is a medicine you're going to have to give more than once a day. And giving a medicine to some of our patients can be a battle every single time if they don't want to take it. So the more times you have to give it per day, the more challenging that might be. Now, fortunately, for most stimulants, there's a long-acting extended release formulation. So that once we determine the total daily dose with short-acting drugs, you can collapse that into a once-a-day morning administration. The problem there sometimes is that the long-acting drugs come in a capsule form that has to be swallowed whole. And many of our patients simply will not swallow pills. There are now some tablet forms for extended release and a liquid form that can be used, which help get around that problem. Finally, psychostimulants are controlled substances so that you can't give a refill to the pharmacy so that the patient can go and get more when they're out. You have to give a new prescription, hard copy prescription, every month, which can be a problem if the family lives some distance from your clinic. You may need to mail it. That could lead to hang-ups in the mail, and it could lead to the individual not having their medication for a few days. So these are the pros and cons of psychostimulants. Let's talk about the non-stimulants and begin with the alpha-2 agonists. So historically, these are medicines that have been used to treat high blood pressure. And these are drugs like clonidine, which is Catapress, or guanfacine, which is Tenex. So these drugs have been on the market a long, long time. We know a lot about them. We use them commonly. And the first treatment I use for ADHD and ASD is an alpha-2 agonist. I begin with generic guanfacine. And because these drugs treat high blood pressure, you need to monitor the patient's blood pressure and their heart rate. And generally in the doses we use, you're not going to see a problem, but it's very important to have a baseline measurement. And when you see the patient, you should make sure that their blood pressure and heart rate are stable. These drugs can be somewhat sedating, and that's primarily the case for clonidine. So it's rare for us to use clonidine during the day to treat ADHD. We're more likely to use it at bedtime, once a day at bedtime, for sleep disturbance. So guanfacine is less sedating, and you usually only have to give it twice a day. So I tend to give it in the morning, and then I tend to give it when the individual gets home from school to help with the afternoon and homework time. And I start guanfacine at a dose of 0.5 milligrams in the morning. It comes in 1 milligram tablets. I give a half a tablet in the morning, and I tend to increase the medicine by a half a tablet per week, giving it morning and after school until we see improvement in symptoms or side effects that limit further dosing increases. And what might that be? Sedation could be one. Now, you don't want to stop the medicine if the person develops sedation early on because it typically wears off. You just may want to go slower on the increase. These drugs can also cause constipation, so something to be aware of, which may already be a baseline problem for the patient. Now, these drugs rarely will make the symptoms worse, which is the reason I tend to start with them. And Intuniv is a drug you'll be hearing about. This is a extended release form of guanfacine that is now on the market, FDA approved for ADHD. Here again, this is a formulation that the individual has to be able to swallow whole in the morning. It's a once-a-day drug, so that could make administration challenging for some individuals. Atomoxetine, or Strattera, is FDA approved for the treatment of ADHD in children, adolescents, and adults with typical ADHD. And it's been studied to some extent in individuals with ASD, and there is evidence that it's better than placebo. This is a medicine that works by blocking norepinephrine reuptake, and it takes 3 or 4 weeks before it's going to work. So this isn't a medicine you're going to see immediate benefit from or that the patient will take and feel in their body. And you have to build the dose up over time. I always start at the lowest dose, which is 10 milligrams per day, and I increase by 10 milligrams per week, giving it all once a day or twice a day. This one again comes in a capsule, so it could be difficult to swallow, although when that's an issue, we've often been able to develop it into a liquid formulation through a compounding formulation pharmacy. So with regard to a stimulant, this is going to be a medicine that will take longer to have effect. The good news is if the patient has tics, this will not make tics worse, nor will the alpha-2 agonist for that matter. And if the patient has a mood or anxiety disorder, this medicine might be helpful with that comorbidity as well. Let's move on to the treatment of interfering repetitive behavior. Now, as I mentioned earlier, there is no drug that's been consistently shown to improve repetitive behavior in autism. So why am I talking about it? Well, I want to show you some of the things that have been studied. And this gets back to the idea of obsessive compulsive disorder, or OCD. And I stress to you that the repetitive behavior of autism is not OCD. Here we have listed the selective serotonin reuptake inhibitors, or SSRIs. And these are drugs that you've heard of. The trade names are things like Prozac, Luvox, Zoloft, Paxil, Celexa, and Lexapro. This is the only class of medicine that treats true OCD. So it was somewhat logical to think, well, maybe they'll be useful for treating the repetitive behavior of autism. And let's see what we've learned. The placebo-controlled studies have shown that SSRIs may be somewhat helpful for repetitive behavior in post-pubertal individuals, but that they're rarely effective in prepubertal people with ASD. Now, you may have patients where this medicine has been helpful, but when we look at the results from large studies of sample sizes of 149 or nearly 200, there's no drug placebo difference. And what we've seen is that these medicines can cause some behavioral activation in people with ASD, things like sleep disturbance, increased irritability, and agitation. So if you're going to use an SSRI, start at a very low dose and go up slowly. But keep your mind open to the possibility that you're not truly seeing a benefit with the drug. These can be given once a day or more, and the FDA certainly has a black box warning around all antidepressants, so that we need to be mindful about the emergence of thoughts of suicide, including in individuals with ASD. Let's next talk about aggression, tantrums, and self-injury. And we group these together and refer to them now as irritability. And as a pediatrician or a primary care doctor, you may be thinking, well, I think you're getting out of my comfort zone now. You're talking about using antipsychotic medications. Aren't those dangerous? And what I'll say to you again is, that's why we're here educating you today. We need your help. There aren't enough child psychiatrists to take care of these patients, and they're out there with these severe symptoms. So I'm going to try to tell you what I think is within your purview and encourage you to try it, because you'll see that it's helpful and then you'll feel more comfortable doing it. So I'm going to talk about 3 classes of medicines that can be used to treat irritability in ASD. We'll start with the older antipsychotics, which I don't want you to use. So the typical antipsychotics are from when we were children, right? These are the drugs from the 50s and 60s that were used to treat schizophrenia. They're very effective, but they're associated with more side effects. For example, if you take these over time, the person may develop abnormal motor movements that may be irreversible, even if you stop the drug. They're usually reversible, but sometimes they're not. And this is called tardive dyskinesia, or slow onset movement disorder. And this might develop the longer the person's on a drug and at the higher the dose, that combination. So it's not going to happen with short-term treatment. And here you're also seeing, we're talking about antipsychotics. I want to emphasize that most people with ASD are not psychotic. These are simply the terms given to these drugs, and I'd urge you to think of them instead as dopamine receptor blockers that we use to treat lots of things like irritability, psychosis, refractory depression, bipolar disorder. And that's the way I'd describe it to the parents, that it's not that we're thinking their child has a psychotic disorder. But these are drugs that you can avoid as a primary care doctor. These are drugs that you need to be using. So the atypical antipsychotics are the second generation, if you will. And there's a lower risk for the development of tardive dyskinesia with these medicines, but for most of them there's a higher risk of increased appetite and weight gain, as well as the possibility of metabolic syndrome, meaning glucose dysregulation and an increase in lipid measures. So let's talk about each of these a little bit. You only have to know about 2 of them. Risperidone, which is the trade name of risperidone is Risperdal. It's available in a generic now, is the best studied medication in autism. And it's approved by the FDA for the treatment of irritability in children and adolescents with autism. So irritability is aggression, self-injury, and tantruming. So you have the backup of the FDA to feel comfortable using this to treat these symptoms in children and adolescents with autism. And how do we dose it? I would start at the lowest dose you can, which would be 0.125 milligrams or 0.25 milligrams once a day at bedtime. And increase the dose by that amount every week in either an all at bedtime or a morning and bedtime manner. And that's very conservative, and you're going to see significant improvement with that approach. So I really want you to try that. I'm a big believer that drugs that don't have side effects don't work. Now, I don't like to say that, but it's true when we're talking about the treatment of aggression or psychosis. That means risperidone has side effects. And what are they? You're going to see increased appetite and potentially significant weight gain. So right from the beginning, you need to be monitoring food intake, diet, encouraging exercise, and limiting access to portion. Not to say that that's easy, but it's important. Not everyone will gain weight, but many will. And the larger the individual is, the more damage they can cause when they hit themselves or others. So it's not a minor problem. Risperidone can be sedating, but it goes away. So don't worry about that. And it also elevates prolactin, a hormone in the body, but all of the antipsychotics elevate prolactin except for Abilify and Clozaril, which we'll talk a bit about. And when the prolactin goes up, your body thinks it's pregnant. And as a result, you can have swelling of the breasts, you can have lactation, you can have sexual dysfunction, You can affect bone mineralization. So these are things to be mindful of, but they're not going to occur commonly. The other drug that's FDA approved for the treatment of irritability in children and adolescents with autism that I need you to use is aripiprazole or Abilify. And again, starting dose is critical. This drug comes in a 2 milligram tablet, and I'd encourage you to start it at 1 milligram a day in the morning or at bedtime, and increase by 1 milligram per week. The maximum daily dose is 30 milligrams, so 1 milligram is quite low. And if this medicine isn't working by the time you're at 15 milligrams a day, I wouldn't encourage you to increase further, because we don't typically see benefit after that. But I would encourage you to increase until 15 if you need to, but you may only need to increase it to 2.5 or 5 or 7.5 or 10 milligrams per day. If you start this drug at a dose higher than 1 milligram per day, the patient's at risk for developing akathisia. And look how we spell that. I want you to spell it correctly. What akathisia is restlessness. The patient feels as though they have ants in their pants. They can't sit down. It causes pacing. And the way to deal with akathisia is to reduce the dose. And if you can't reduce the dose without losing benefit, you can then add Inderal or propranolol to treat the akathisia at doses of 10 milligrams twice a day up to 40 milligrams or so twice a day. And that can be very helpful for akathisia. Sometimes you'll see nausea, but not if you begin at a low dose and go slowly. And sometimes you'll see sleepiness. If you see sleepiness, move the dose to bedtime. One of the benefits of Abilify compared with risperidone is that it does not elevate prolactin. I'll just mention some of these other medicines, but I think that your responsibility is to try risperidone and Abilify, and then beyond that, let the psychiatrist or neurologist do this. So olanzapine or Zyprexa, there's very little data on it. It's probably the most likely atypical antipsychotic to cause weight gain and glucose or lipid dysregulation, but it can be treatment responsive for aggression. It's also sedating. Quetiapine or Seroquel, there are no controlled studies of it in ASD. Some of you may use it to treat sleep disturbance. I'd encourage you not to do that. You don't want to use a drug that can cause tardive dyskinesia to treat sleep disturbance if the patient wouldn't be on quetiapine anyway for some other comorbid disorder like aggression or psychosis or bipolar disorder. This medicine can also increase appetite and cause weight gain. If you go up on the dose too quickly, it can cause orthostatic hypotension, and it can be quite sedating. Ziprasidone or Geodon is unique among the atypicals in that it does not cause increased appetite or weight gain. And as you're seeing, that's a big concern with these medicines. So if you have a patient that's obese at baseline who has gained weight to the point that it's treatment limiting, you want to consider ziprasidone, even though there are no controlled studies. Now, the other thing with ziprasidone is you never want to give it to a patient with a known cardiac problem because it can prolong the QTc interval. The other atypicals can also prolong the QTc interval. But you would want to get a baseline EKG with ziprasidone and have one at some point along treatment progression. This medicine must be taken with food or absorption will be inadequate. Paliperidone or Invega is simply an extended release form of risperidone that I just wanted you to have heard about. So it's a once-a-day extended release form. Again, it's a capsule, so the patient would need to swallow it, and there are no controlled data with paliperidone in ASD. Clozapine or Clozaril, I never want you to use. I use it rarely, but in treatment refractory cases of aggression, or when the patient has developed catatonia, this can be a life-saving medication. The reason we don't use this commonly is it's the most likely among the atypicals to lower the seizure threshold, and you have to have your blood drawn every week for quite a period of time before you can get a refill of the medicine, because it can lower your white blood cell count. So there's a lot of protection built in to ensure safety of the patient, but it makes it challenging to use for many of our patients. You've heard of mood stabilizers like valproic acid or Depakote, lithium, carbamazepine or Tegretol, gabapentin or Neurontin, topiramate or Topamax, lamotrigine or Lamictal. Many of these are also anticonvulsants. These drugs typically do not treat aggression in ASD unless there's a true identifiable bipolar disorder. So I wouldn't encourage you to use these very commonly for treatment of aggression and irritability in ASD. What about treating depression in ASD? Well, first of all, it can be difficult to diagnose depression with confidence, especially if you have little experience doing it. Because, again, many of these people have significant communication problems. So when you say, "How do you feel?" they can't tell you. So when you're looking for depression, you're looking for the, quote, neurovegetative symptoms that may have changed: sleep disturbance, reduced energy, reduced or increased appetite, lethargy, reduced interest in things that used to bring pleasure, non-compliance, those kinds of things. And the other thing you're looking for is a typical age of onset for something like depression. So if you have a person in their late teens or early 20s that develops a major change like this, you want to think about depression. There are no data that have been published on treating depression in ASD of any age, no systematic data. So you're kind of on your own, but this is what I tend to do. I often begin with bupropion or Wellbutrin because it doesn't cause any increased appetite or weight gain, and it's often a bit more of an energizing antidepressant. And many times these people have lethargy and low energy and lack of an interest. This drug can lower the seizure threshold, so I don't use it in people with a known seizure disorder, although I've never seen it cause a seizure in someone without a seizure disorder. And you want to dose this cautiously. Again, begin at 37.5 milligrams a day and go up gradually. Venlafaxine or Effexor is something I also use, and again, it is a bit more energizing. It can elevate blood pressure, but I don't see that commonly. And you want to start again at 37.5 milligrams and go up slowly. Duloxetine or Cymbalta is a newer antidepressant that increases both serotonin and norepinephrine, as does venlafaxine, and we've had some success with it. And finally, at times I will use SSRIs to treat depression, although again I find them to be a bit activating in these people and tend to stay away from them. Anxiety is quite common in people with ASD, and this will show up, for example, when they're trying to transition from home to bus to school or home to work site, for example, and there's a lot of behavioral problems. That's anxiety. I start with buspirone or Buspar, which many of you have heard of but have rarely used, but it can be quite effective. It comes in a 5 milligram capsule. I begin at 2.5 milligrams a day, and I increase by 2.5 milligrams per week, alternating between a morning dose and a dose after the person's done with their daily activities. And the onset of the effect will be gradual. It's not immediate, and you may need to get to a dose of 5 milligrams twice a day up to 15 milligrams twice a day. But there are essentially no side effects with Buspar, although I find it helpful. Mirtazapine or Remeron is my second-line drug for anxiety. And the main side effects of this drug are sedation and increased appetite and weight gain. Many people that are anxious have trouble sleeping, so the sedation can be useful, and we give this drug all at bedtime. And you'll just have to monitor the appetite and weight gain. Many people who are anxious are quite thin, so it can be helpful. This drug comes in a 15 milligram tablet, and I start at an extremely low dose of a quarter of a tablet, or 3.75 milligrams at bedtime, the maximum daily dose being 45 milligrams. And I go up by 3.75 milligrams a week until I see benefit. As I've emphasized, you can use SSRIs, but because many of us find them activating, they may not be that great a choice for anxiety. Sleep disturbance is a big problem in ASD, and there's very little data, so I'm going to quickly tell you what I would do. I would start with melatonin, which is over the counter. The family can buy it at the drugstore. And I would encourage them to buy 3 milligram tablets. Take 3 milligrams for 2 or 3 nights. If it isn't working, go to 6 milligrams. If 6 isn't working after 2 or 3 nights, go to 9 milligrams. And if 9 milligrams doesn't work, melatonin will not work. You could then try clonidine at a dose of 0.1 or 0.2 milligrams at bedtime. The problem with clonidine is it may initially help the person fall asleep, but you may find that they start waking up in the middle of the night. And if that occurs, you're probably done with clonidine. The most effective drug I have for treating sleep disturbance in ASD is trazodone or Desiril. And I would start at a dose of 25 milligrams at bedtime, going up by that amount each week to a dose of 200 or 300 milligrams if needed. It's important that you know that in males, trazodone can cause priapism, which is a sustained penile erection. It's rare, but if it happens, it can be a medical emergency if it lasts longer than 4 hours. Now, in 24 years of doing this, I've only seen this once, and it didn't progress to an emergency, so it's rare. And I wouldn't not use trazodone for that reason because it's so helpful. But if you have a minimally verbal, cognitively impaired adolescent male, you want to do your best to educate them about that possibility. The others you can think of down the line, you may run into trouble with benzodiazepines like Ativan, Xanax, or Valium, because you could cause a paradoxical or worsening rather than a calming, and the same is true with Benadryl or diphenhydramine. This next area is probably out of your zone a bit, but it's very common for adolescents with ASD to develop inappropriate sexual behavior. In reality, the things they're doing are no different than the things we do, except they don't know that they should do them in certain places. And that's where it isn't really fair. So they were given normal sexual functioning, but inadequate sexual judgment. So it's really on us to educate them on how to deal with this appropriately. And you want to start with behavioral strategies, teaching them where they might masturbate or whatever they're going to do. Let's not assume they're not going to do it. Teaching them about sex a little bit. And if those things aren't working, then you might try a medicine. There's some data that suggests that mirtazapine or Remeron could be quite helpful in reducing hypersexual behavior, starting at a dose of 7.5 milligrams at bedtime and increasing up to 45 if needed. SSRIs might be helpful, although less so. And finally, if the behavior is putting the individual or others at risk of danger, hormonal strategies can be pursued, such as using oral progesterone or medroxyprogesterone or injectable depo-progesterone. And I've had to do that in a handful of cases over the years just to allow the person to have a quality